So our neuroblastomas arise from our sympathetic nervous system, brain and spinal cord. They can begin in the adrenal glands, which are the little hats on top of our kidney. But it resembles a Wilms tumor. So don't think that, in the medical field, we see signs and symptoms, we do physical assessments, and we run tests. And that's how we differentiate and we rule out different types of cancers. So it looks like a Wilms tumor in its initial stages, but usually it's highly malignant, which basically means it's bad. Now, malignant, mal, in the Latin language, is bad. Mal is bad. In our Wilms tumor, they're mostly benign or they're encapsulated so they're not spreading all over the body. This is highly malignant in our neuroblastomas, and they spread to the bone, marrow, liver, and lymph nodes, and it's spread all throughout the body. Usually when your patient sees the signs and symptoms, it's already too late, and it's already almost like a stage 4, and it's spread throughout the body. So what we're going to do is we're going to obviously do a physical assessment on our patient. There's going to be weight loss. There's going to be anorexia. Your patient's not going to want to eat. There's going to be enlarged lymph nodes with bone pain and decreased RBCs and platelets. Because if it's spread to the bone marrow, we know that the RBCs are made in the bone marrow. If it's spread to the liver, we know that our coagulating factors, like our platelets, actually the utensils that need to help the platelets to coagulate, it's going to be decreased. Bone marrow is going to have impaired function. Liver is going to have impaired function. So what do? We're going to try to wipe it out with our two biggest things here, chemo and radiation. Now we're going to use chemotherapy because it goes throughout the bloodstream, and if it's metastasized everywhere, so let's say the marrow, the liver, and the lymph nodes, we're going to try to get it all with our chemotherapy patients. Now, we did another video on chemotherapy drugs, and things to watch out for if your patient is neutropenic. But the biggest thing, guys, with neutropenic patients, especially if we're wiping out their white blood cells, all we're trying to do is wipe out, with chemotherapy, the fastest replicating blood cells. So white blood cells, bad cancerous cells, even good cells, we're going to wipe it all out. So with our neutropenic, low white blood cell patients, so wash your hands, no fresh fruit, and no flowers, okay? Like no flowers, like picking flowers. That will probably be on your test, okay? So don't do it. We made a whole other video for that, so you guys need to check that one out, because this is our oncology section. And next, we're going to talk about bone tumors here. So bone tumors, we're talking about our osteogenic sarcomas versus our ewing sarcoma. So let's get into ewing sarcoma here. Ewing sarcoma happens inside the bone marrow, usually in long bones, and our biggest long bone in our body is our femur. So our femur is most affected inside the bone marrow itself. Now, there's no amputation involved with this type of bone tumor. And I want you guys to highlight that. Because in osteogenic sarcoma, there is amputation. So how do we manage in ewings? We give high-dose radiation with chemo, okay? Just like we manage any other cancer. We're We're trying to give radiation to shrink the tumor. We're trying to give chemo to bring make sure that all the cancer cells don't reduplicate, kill those off, and your patient's going to have low white blood cells, very, very susceptible to being sick and septic. So remember, guys, neutropenic precautions, no sick people, no crowded areas, no fruit, flowers, and no, there was something else. Wash your hands, okay? All right, osteogenic sarcoma. We have tumors growing inside of the bones here. It's growing at the edges of the growth plate in our long bones. So I want you guys to think growth plate inside the long bones. And yes, we can do amputation, okay? So amputation is a must. And our same old radiation and chemo. Radiation, chemo. Same. Shrinking the tumor, making sure no other cancer cells reduplicate. Now your signs and symptoms of your osteogenic sarcoma is you get pain with activity, you have a tender mass, and you also get pathological fractures, basically little fracture lines. And if you guys remember that you have tumors that are growing along the growth plates or near the growth plates, then we can remove these tumors through amputation, not so in Ewing syndrome or Ewing sarcoma, because that's in the bone marrow. These are along the growth plates, so we can just do a amputation. Now, if your patient goes undiagnosed, it's usually a 5-year marker for a lifespan. And these two happen a lot in our pediatric communities. So it doesn't mean that it's going to happen at 5 years old. It means that there's a 5-year lifespan, 5-year prognosis in terms of your patient with osteogenic sarcoma. And that's it for our neuroblastic conditions in our pediatric patients, guys. Thank you guys so much for watching. Wilms tumor is our next pediatric oncology type of tumor that happens inside the little nephro unit of the kidney. Now, it's also called a neuro-blastoma. It's a type of neuro-blastoma. Fancy words for a tumor growing in the functional part of the kidney, the nephron, okay? There's like a little tumor growing inside the kidney. A type of neuro-blastoma is a Wilms tumor. Usually it happens between the ages of 1 to 3 years old. Mom will take home a little baby and a washing little baby and find like a little tiny pea or peanut sized lump right next to the liver. Usually it happens to the patient. It says on unilaterally, basically on one side, one kidney. So mom will find a lump and take them to the doctor. Doctor will either aspirate it, do an ultrasound, and they'll diagnose a Wilms tumor, or they'll finally find a cause of why the lump's there. But usually that's how they find the tumor. So, tumor is in the kidney. You have a good prognosis that none of it will spread. And they say this because the tumor itself is encapsulated. So the cancerous cells are encapsulated on itself. So what they can do is they usually go in after they find the tumor. They'll go in 24 to 48 hours immediately after finding it and cut it out. They'll exercise it. They'll basically take it out. The other downside is if your patient palpates it, because it's encapsulated, if we're pushing on it, palpating it, some of those cancer cells might get out. So, they say do not palpate the area. Don't do it. That is a huge key word for you guys. Let's see here. The mother notices the mass. That's right. It's going to be tender. And another sign is that your patient might have a hematuria, blood in the urine. And that's because we have a little mass growing in our kidneys. So, we're going to do surgery to take it out. We can also do chemo and radiation, not always indicated, but just make sure not to palpate the mass. That's it. Let's go on to neuro-blastoma. And